Hello, good afternoon,
This
everyone.
meeting is being recorded.
If we can ask you all to kindly mute your mics. We are so happy to have you all participating in today's training regarding the treatment of co-occurring mental health and substance use disorders. Sorry. I think most of you on here are very familiar with these topics, that the majority of people who have a mental illness also have a co-occurring substance use disorder and vice versa. So we really are excited to be able to provide this training to everyone, to talk a little bit more in depth on how we can effectively treat these co-occurring disorders together. For those of you who are in need of CEUs, we are going to be providing 1 CEU credit for social workers, LCDCs, LPCs, and LMFTs. So at the end of this session, we are going to have a link to a survey for you to complete. And when you turn in that survey, that will allow us to be able to send you your CEU. So please be sure to stay on for the duration of this training in order to get the information for your CEUs. And so with all of that being said, and without further ado, I do want to welcome Diane Arms, a longtime NBHP friend, who is the new recently promoted director of behavioral health, clinical director of clinical behavioral health. Diane, you just told me and I forgot, so you will let people know who you are.
Yes.
But please welcome Diane.
Thank you. Thank you, Andrea. I am incredibly excited to be here. Here we go. Co-occurring disorders is very important to me. I have been at the intersection of mental health, substance use, and healthcare for quite some time in my career now. I currently serve as the director for clinical behavioral health at the council. It's a very new role, so it's okay, Andrea, I forgive you. It literally happened, I think, last week. So, but I'm glad to be here. A little bit of my history is I have worked in the local mental health authority setting in El Paso, Texas. I have worked in community-based organizations providing oversight of substance use outpatient, residential facilities, and medication-assisted treatment centers. I've also worked at and with federally qualified health centers. So integration has been the word for me, I think, since 2019. I kept saying in 2019, integrating. And then we all know that what happened with COVID and everything, but integrating is still the word. So this is a really important quote for me that I put in almost all my slides in all my presentations, because it talks about, it's time for state and local systems to begin to systematically implement what is known routinely provided MH and SED services for the high risk, high volume, poor outcome populations with complex needs. It's also time for federal, state, and local research funders, academic institutions, and other entities which routinely evaluate population health efforts to make the same level of investment in the study of systemic mental health and substance use disorder integration efforts as it has already been done for primary health behavior health integration. And I'm especially excited to put it in this presentation because NBHP is leading this this presentation, but because they're such an advocacy organization. Sydney is a fellow policy at NBHP, and so it's time that we start stepping up and making more of these statements and requests to those people who are sitting at the table and making those rules. So we are going to do an activity. So get your phone out. I'm going to stop sharing and share a different screen. Let's see. And I'm gonna ask for your forgiveness and some grace on the front end because I am not that great at technology. So present that. All right. So what are you or your organization doing about co-occurring disorders? If you can text Diane Arms 865-222-333, and then you can put in your response. So we'll give you a couple minutes. Has everybody been able to, there we go, hosting this training, yes.
I'm sorry, did you say you wanted us to text at the top, this information at the top?
Yes, you would text that information at the top.
Okay.
And
you
and then
this kind of thing.
and then you would put your answer. Okay, I recognize my limits and refer. Good, that's something. Working together, counselors and peer support specialists. Offer therapy and refer to partnering organizations for support. Refer out. Not much. Mental health referrals and screening. COPS-D. Hiring more LCDCs as part of a multidisciplinary team. Refer out, refer out. Integrated BH and other services. Collaborate within same agency and refer out. Everything seems to fall under case management umbrella, but often feels like blindly throwing darts. Ugh. And have a, yes, I am so sorry for that. Prevent substance abuse for symptomatic clients. Multidisciplinary teams. Offering individual and group therapy in the psych hospital I do PRN work with. Trainings and collaboration with the Harris Center. Shout out to the Harris Center. All right, so we're going to go ahead and go back. I wanted to get a little bit of an understanding where we are in this group. So stop share. All right. So today our objectives are going to wake you up. Hopefully we already did that check with the activity that we just did. We are going to talk about the history of mental health and substance use. We're also going to talk about the history of co-occurring disorders, going to give some statistics on co-occurring disorders. And then the best part is talk about resources that you can use. So, history of mental health. Does anybody know what this is called? Trephination is what it is called. And it was actually recorded in 65. Can somebody mute their phone, please? Thank you. It was recorded in 65 6,500 BC, that the drilling of holes in the skull would alleviate psychological disorders. Then in 1900, we heard about the wandering uterus and how that was a mental health issue as well. But if you can acknowledge, both of these really had to do with physical symptoms. The reason I'm saying that is that mental health, even in its earliest form, has been part of something that is more physical than just affecting the brain or the mind. And now, because of that, we have pushed to see mental health just as important as physical health and part of overall health of the and well-being of an individual, which is so exciting. And it's an incredible advancement for not just our clients, but us as members of the mental health field, to be able to say, okay, it's validated that what we do is just as important. So it's been referenced throughout history, but there really hasn't been there wasn't a diagnosis system until like the late 1800s, which was the DSM, which all of you, I'm sure, are aware of. So history of substance use has a very different history, right? It's been around as long as recorded, but it was used to ease certain ailments. So here, you have a toothache. Oh, you know what? Let's just go get some cocaine toothache drops. That'll be, they're 15 cents and sold pretty much everywhere. But what about our kids? Oh, the kids are, I don't know if you can see this whole thing. The kids are teething. Let's go get some of Miss Winslow's soothing syrup. But this is no different than what has happened in the recent years with the opiate epidemic. We overprovided. We saw that there was a solution to an ailment, and we overprovided and overprescribed medication. And because of that, we have had 70% of the 71,000 deaths in 2019 of overdoses were specifically due to opiates. So again, I really want you all to make sure that you see the distinction of how mental health has been portrayed in history and how substance use has been portrayed in history. And that difference leads to standardized manuals like the DSM, identifying substance use as more of a personality issue. So if you can see here, this table represents the changes within the DSM versions regarding substance use disorders and the complexity of the disease alone. So in the first DSM, they talked about the terminology. They used drug addiction, alcoholism, and they categorized it as a sociopathic personality disturbance. Again, this is important to note because the way we have historically looked at substance use has been such in a negative way that has been a barrier to introducing substance use in other facilities, like a primary care facility or even mental health facility. And so because of all these changes, thank goodness now we look at the DSM-5 and it's classified independently. And although, SUDs are commonly seen in individuals with antisocial personality disorders, that's not just the only way they're being seen. Let's see. So a little bit of a timeline of co-occurring efforts. Throughout the last couple of decades, specific funding was provided to academic institutions to really push co-occurring disorders, or what they were trying to call co-occurring disorders. In the 1970s, co-occurring mental health and substance use disorders were identified as a population of significance. In the 80s, dual diagnosis was termed, and there was research on integrated treatment. In 1999, the National Association of State Mental Health Program Directors and National Association of State Alcohol and Drug Abuse Directors issued consensus about supporting a 4-quadrant model. The 4-quadrant model runs from less severe to more severe, on either axis is mental health and substance use. And what it states is that you can have substance use and mental health in these 4 different quadrants, where these 4 different locales of service. So for example, the first quadrant would be you're low on mental health and you're low on substance use. So you would essentially be treating that something like in primary care. Second quadrant would be you're looking at high mental health, low substance use, maybe at in a mental health institution. Third level of care would be high on substance use, but low on mental health. So perhaps somewhere where there's more significant substance use treatment. And then the fourth would be high mental health and high substance use. This 4-quadrant model is incredibly important because it shows that in each of the areas, there should be a door to talking about mental health and substance use together. So fast forward to 2002, SAMHSA says that co-occurring disorders are an expectation, not an exception. In 2006, however, there's a shift from mental health and SUD to primary health and behavior health due to the research on the life expectancy gap for adults with severe mental illness. So this was a very big shift, because at first we were talking about, oh, let's do mental health and substance use together. But at this point, people were like, let's kind of tackle one thing at a time and try to see if we can get that mental health addressed, since that's where we're seeing the biggest bang. Like, we're seeing more individuals die younger. We're seeing more individuals with other physical health ailments that are having poor outcomes because of this severe mental illness. Well, that was great. And because of it, a lot of you can recognize that there's some mental health in each of the facilities, whether it be primary care or substance use, but mental health is being at least assessed or maybe screened for at different facilities. So then fast forward to the opioid epidemic, just like we talked about right now, that became such a huge issue that the resurgence of co-occurring disorders is starting to happen. People are starting to realize, wait, we made a mistake. Like, we should have never separated these two in the first place. So let's talk about some statistics. So 42.0 million people, and this is a statistic from National Institutes of Health of 2019. So mind you, this is probably blown up even more because of COVID. So 42 million had just any mental illness, but not a substance use. 51 had any mental illness with substance use. 19.3 had just a substance use disorder, or I'm sorry, 9.7 just had a substance use disorder, but 19.3 had substance use disorders. But look at that number in the middle. That's 9.5 million people that had a substance use disorder and any mental illness. And this is specifically talking about diagnosable mental illness. So co-occurring disorders, the definition is somebody that has a substance use disorder, but does not necessarily have to have a mental health diagnosis, because sometimes people don't meet the criteria, but they still have levels of depression or they still have some sort of anxiety. If we looked at it that way, this number would be so much higher. So with that being said, who gets treatment? There are effective treatments, but not everybody with co-occurring conditions gets the treatment they need. So if you look at the pie chart, 52.5% of the people in this study done by a National Institute of Health received neither mental health care nor substance use treatment. That's 52.5% of individuals walking around with untreatable a condition. And if you can think, what would it be like if we had 52.5% of people with diabetes walking around without treatment, or 52.5% of individuals with cancer going without treatment? That's a really high number. So 34.5% of the individuals received mental health, but did not receive substance use treatment. So that's the bigger chunk of the pie, which is good. We're glad that people are getting their mental health services. But what does it do for substance use? Only 3.9% received substance use treatment only, and 9.1% received both mental health and substance use treatment. So now if we look at it like that, and we say only 9% of the population who has co-occurring disorders received treatment, even that's bad, right? Like that's 10 times worse, or well, not 10 times worse. I'm not that great at math, but I mean, it's so bad. It's so abysmal to think that individuals who have these issues are just not getting the treatment. So why don't they get treatment? Unsure. And please put in the chat, if you agree or disagree, or if you have any other ones that you would add to this list. People don't get help because they're unsure if their substance use or mental health issue warrants help. They may think that it's incredibly difficult to know what level you're at. There's oftentimes a gray line, and we have to make people comfortable to say, even if you're at the gray line, you can still receive some type of assistance. So they're also afraid to fail. Many people fail at being sober. It's actually part of the process. You've heard fall off the wagon, right? They're afraid to fail, and so they choose not to go to treatment. Also, they don't believe they deserve the help. Self-esteem and self-worth, which I know I am preaching to the choir, can be much lower than other people realize. So it's hard for individuals when there's so much societal pressures to think that, oh, I have to be the mom who takes the kids to soccer. I have to be the mom who makes sure that the house is clean. I have to also enjoy my friends' time, and I have to do this, and I have to do it all without feeling anxious or feeling sad for myself. And that's not okay. Like, we need to make it more we need to make it easier for people to ask for the help that they need. And then, of course, there's also internally, some people suffer from denial. They think that they don't have an issue. Some external reasons why people don't get help: affordability. I don't know how many administrators I have on the call today, but you know that the payment, there is no parity for mental health and substance use, although people try to say there is. There's definitely no parity when it comes to healthcare as well, even though mental health and substance use both impact somebody's external or physical health. Liability on providers. I've worked with medical providers who were saying, I don't want to even touch somebody with mental health or substance use disorders because that's a liability on me, not realizing that it's a liability on them either way. This goes back to the lack of education and training. Something that the council is doing is actually providing education and training to medical doctors who are still in school, kind of more upstream, so that they can see and understand about substance use and how it is a medical disease, and how important mental health is to be addressed even when they're in the primary care settings or whatever setting these individuals are going to. And then also duplication of services. A lot of individuals say, okay, well, if they're already receiving that over there, you know, I shouldn't have to help. Well, maybe they're receiving that over there, but the communication between you both is non-existent. And so that doesn't help the patient either. So with having the thought that, oh, we're going to duplicate services when you don't even know what services they're being provided, could also be an external reason why people don't get help. But one of the biggest reasons that people don't get help still is stigma. It's really unfortunate to see how many people come to our office and, you know, are ashamed to even just walk into it because it says Council on Recovery. So this is another way to look at what I just stated, but with numbers, if you're a number person. I'm not sure if you can tell, but I am very visual. My slides don't contain a lot of words because I need to see things to be able to kind of process them. So if you look at the one on the left, which would be your left, yes. Left would be with individuals with co-occurring disorders who did not receive mental health care. One of the top reasons was could not afford cost. Ugh. They didn't know where to go for treatment. They could handle a problem without, they felt they could handle the problem without treatment. Fear of being committed might cause neighbors to have negative opinion, didn't think treatment would help, didn't have time, concerned about confidentiality. Now, if you look at on the right side, this was the study done, but this was also for substance use. So this was among adults with co-occurring disorders who do not receive substance use care. And the reasons for not receiving it were they weren't ready to stop using. They had no health insurance and could not afford costs. So that goes back to the affordability. Might cause neighbors to have a negative opinion. So that's stigma. Might have negative effect on job. Stigma. Did not know where to cover treatment. Had insurance, but didn't cover treatment costs. So again, affordability. Most of these things are things that we can fix if we work together. Didn't know where to go to treatment? Well, I'll give you a resource so that you can know where to go to, where you can send your individuals to treatment. The stigma, we can all be a part of changing that and destigmatizing mental health and substance use and co-occurring disorders. So why is it important to understand co-occurring conditions? Co-occurring co-occurring disorders don't just happen unilaterally. Mental health doesn't cause substance use, and substance use doesn't just cause mental health, although that's what people think. There's so many different ways that substance use and mental health interact. But there's one thing that's for sure, that both of them together worsen mental illness and increase dependence. I wanted to add this in there because I know we're talking about mental health and substance use, but it's also really important for me, as I've stated in the beginning, that the intersectionality of health and mental health and substance use, people want to receive services in primary care. People are being seen for, so some of these issues, maybe they have an ulcer. Is their doctor asking them if they drink? Maybe they have frequent colds. Maybe they fall down the stairs and they're like, okay, I'm going to code this as a broken arm, but instead it should be coded as this individual had, 4 bottles of wine last night and clearly could not make it up the stairs, and that's why they fell. There's so many physiological effects of using drugs and alcohol that we need to start looking at integration more differently. If we continue to sparse them out, we're doing a disservice to our client by not recognizing that one is affecting the other and that they could have better outcomes. But we are making progress. So the Surgeon General stated, well, services for the prevention and treatment of substance misuse and substance use disorder have traditionally been delivered separately from other mental health and general health care services. Effective integration of prevention, treatment, and recovery services across healthcare systems is key to addressing substance misuse and its consequences. It represents the most promising way to improve access to and quality of treatments. And then in addition, SAMHSA developed the Center for Excellence for Integrated Health Solutions, specifically to address mental health and substance use disorders concurrently. And that's a great resource for individuals who are looking for, where do we even start? How do we, what are the best practices? Another big thing, and stay with me, I know I'm going off on a tangent here, but another big thing is that the definitions of substance use are now labeled as, the first one is from the American Medical Association, that addiction is a treatable chronic medical disease involving complex interactions. The reason that's so important is that if we can identify that substance use and mental health are part of a medical model, the easier it is going to be to integrate, the better it is going to be to integrate. We have got to start realizing that it's not just physical health that completes an individual. It is you have to consider mental health and substance use. The second definition is from the American Psychiatric Association, where it says it's an inability to consistently abstain, there's an impairment in behavior control, and it's a dysfunctional emotional response. And then according to ASAM, which is the Society for Addictive Medicine, it's a complex condition, a chronic brain disease. If we start looking at it like that, then hopefully we can also destigmatize. Now, it wouldn't be a fair presentation if I didn't put a plug for our services at the council. We acknowledge that substance use is on a continuum, and people go through the continuum back and forth. They can go through the continuum back and forth. And we also acknowledge that co-occurring disorders is an important piece of the work we do. So with that, we offer services for mental health and substance use concurrently, and we address them across different stages of life. So we're in elementary schools, we work with the geriatric population, we are working with individuals of all socioeconomic status. So if you have an individual who has any type of substance use or any type of co-occurring disorder, we would be the greatest place to start. We have state-funded contracts. We've been around for 75 years. So we are able to have those connections within the community to help navigate individuals to where they need to be. We don't provide residential facilities. We don't provide inpatient or detox. But what we do is we establish communities and maintain those relationships, so that way when somebody comes to us needing those things, we hold their hand until they get there. So that's my selfish plug for the Council on Recovery. So we are going to do another activity. I am going to ask you all to put in the chat. I'm going to ask you a couple questions, and there may or may not be a prize for each of the questions. So the first question is going to be, does everybody have their, I can't see people right now. Let's see. Oh, it's fine. Does everybody have their chat open? All right. So the first question, perfect. That wasn't one of the questions, but thank you for validating that. The first question is, how many individuals were in 2019 had both a mental health and substance use disorder? And you put yes, it was 59.5 million. There's our answer. Who got it first? It was Patricia McElliott. Yes, thank you. All right. There is something coming your way, Patricia McElliott. Our second question. The wandering blank was an actual mental health term. Yes, uterus. And who was the first person who did that? Oh, Araceli Olivares. Andrea, do you think you can get me their emails? I think she's on mute.
I can.
Okay. All right. Well, the next question. So we have 4 questions. We have 2 more. Everybody ready? I can't type fast. What was the main reason for people, for people not receiving shame and stigma? Wow, I didn't even, yes. All right. Who is the first one? I'm gonna give it to, I'm sorry if I'm blocking your name, Diane Blackwell. And then what about the main reason for external? Cost, Annabelle. Good job, Annabelle. I didn't catch Annabelle's last name. That went way too fast. Oh, where did it go? Cost, Annabelle Morales. Perfect. All right, so the people I got, if you can go ahead and send me their emails, Andrea, it's Patricia McElliott, Araceli Olivares, Diane Blackwell, and Annabelle Morales.
Got it.
Thank you, ma'am. All right. So now, because that was very intense, and I do this because all of y'all are in mental health, and we need, or in the field, right? And we need some time to ourselves. We need to breathe in, we need to breathe out. We do incredibly amazing things. So I am going to put my timer on for 1 minute. And if nothing else, if you get nothing else out of this presentation, you at least got a minute to just be. So we're gonna start the timer right now. And I just want you to box breathe. If I'm sure you all know what it is, but if not, it's breathe in for 4 seconds, hold for 4 seconds, breathe out for 4 seconds, and then hold for another 4 seconds. And we are starting now. All right. Well, thank you guys for being for participating in that. Okay, so key takeaways. Co-occurring disorder should be addressed in different settings. There should be no wrong door. Trauma should be addressed in co-occurring disorder treatments. Different levels of integration and lack of common language leads to limitations. Screening, assessment, and subsequent diagnosis is imperative, and clients with co-occurring disorders should be the expectation, not the exception. So what can you do? There's 4 things that I really, well, that I think you can definitely do. People first language. Using people first language with mental health and substance use can destigmatize, help destigmatize these specific diagnoses. And by helping to destigmatize, you're helping people get the treatment that they need, right? You're getting them to that area where they're like, okay, it's okay to ask for help, especially after COVID. Assess and screen. If you need assistance with what assessment to use, what screening tool to use, you can definitely reach out to the Council on Recovery, as our Center for Co-occurring Disorders has a beautiful Excel spreadsheet with plenty of assessments to look at mental health and substance use disorders that we've actually provided to federally qualified health centers that we're working with to see what works best. It gives the breakdown of whether you have to buy the assessment, whether you have to, whether it's in Spanish, whether it's self-administered. It has a ton of different variables that you can look at and choose the best one that works for you. And then if you don't provide the treatment, that's okay. Not everybody can do everything, but of course we'd be here to help you if that would be something that you'd want to do. But if not, you can always refer to us. Like I said, we're the first place to start. Or like people said, they were referring to the Harris Center or other outpatient residential facilities, but make sure that that referral is a warm referral, that you work with the individual to get them to the place that they need to be. And then you can call us. I am going to show you my LinkedIn QR code, and you can go ahead and send me a message if you like. But I'm going to put our phone number in the chat, and that way, let's see, 855-942-4100. Call us because we can help. Okay. So now one last activity. What are you and your organization going to do to address co-occurring disorders? If you'd like to put it in the chat, we can do that, or we can go back to the text message. Let's do that, actually. Let's go share screen. Here we go. Here we go. Activate and share screen. Beginning to administer screeners to catch substance abuse issues in earlier treatment. Awesome.
There are a number in the chat as well, Diane.
Perfect. Okay, thank you. Staff clients with the expectation in mind. Pre-screening is part of workup. Somebody muted me. Educate, educate, educate. Yes, I love it. Man, you all really are a great audience. Advocacy and policy change. Refer to Harris Center. Consumer training. All right. Well, thank you, everybody. That is refer to you guys when having a hard time getting to inpatient. Yes, please. So let's go ahead, and I'm just going to put my slide up so that way you guys can have my Again, I told you I'm not good with technology, so I apologize. And I'm just going to leave it there. All right, so that is my QR code for LinkedIn, and I'd love to take any questions. We still have about 10 minutes.
Are there any questions? Okay. All right. Well, thank you so much, Diane. Well, there is one now in the chat.
Yes. So Annabelle, there's actually quite a few different screeners, and it's just dependent on where you're at and what's most appropriate for your clients. If you email me, I can email you that spreadsheet of all the different screeners that we've looked at, and we can go ahead and fast forward and send you that, forward that to you. How about citizenship, immigrant eligibility for services at the council? We serve everyone. I will say that. We, regardless of ability to pay, regardless of status, we will serve everyone. Now, there's some programs federally funded or state funded that are specific that may ask for that, but we still serve everyone. All right.
Okay. All right. Well, thank you so much, Diane. We really appreciate it. We are going to put the link for the survey that you need to complete for the CEUs in the chat, and ask that you please take just a few moments to complete that survey. We will be providing, it was just in, maybe put it in one more time, Sydney, please. It keeps on going up with additional comments in the chat. There it is again. It'll just take one moment, and it's folks who are either LCDCs, LPCs, social workers, and LMFTs will be eligible for the CEU. I don't know that we can give one whole CEU because we ended a bit early, but we will get that out to you after you complete the survey. We'll just give a few moments for people to see that link. You just click on that, and it'll take less than 60 seconds if you do need that that CEU. And it also will be for individuals who joined prior to 1:15 as well.
And I will stay on for the next 10 minutes in case you do have any questions to meet your 1 hour mark.
And thank you all so much.
Excuse me, where's the link for the survey?
It's in the chat.
Okay.
Yes, Amber, you can, if you email me, I can go ahead and send you a list. Oh no, that was the assessments. Yeah, I can send you a list of resources as well. Just go ahead and email me. And we have a list of resources that we utilize when somebody comes into our intake or our OSAR, which is Outreach Screening Assessment and Referral Team. And then that depends on like whether they have insurance or not. So we can go ahead and provide you with that. Just go ahead and email me.
And we're going to go ahead and stop recording, and thank you all. We're not going to be able to